Well, thank you for that nice introduction. Lovely to be back here again, and I'm very grateful to have been invited to talk to you again. This is just a quick run through something that is very important and increasingly important to everybody, and it should not strain your brain too much before a belated lunch. So there are just quickly 4 cases to go through. First one's a 2-year-old male who was referred from his general pediatrician because it was thought there was some virilization. His penis had enlarged apparently over a duration of 6 months, but there had been no other virilizing changes and no reported growth concerns by the family. He was a full-term baby with a normal birth weight. I understand that this is not my patient. I understand that he had macrocephaly, but so did other family members, and it was thought to be familial and of no consequence. On examination, he was tall with an appropriate weight for height, being above the 97th centile in a family with a mid-parental expectation on the 50th centile. The only abnormality was that he had a significantly enlarged penis without pubic hair and with no testicular enlargement, and there were no cafe au lait marks or other things to suggest a cause. So he had a number of investigations. There you can see the growth chart on the 97th centile with the MPH on the 50th. He had a whole lot of tests that you would expect to do to exclude androgen excess of some sort, to look for an adrenal cause with DHEAS, to look for a central cause with gonadotropins. And the only thing that was abnormal was that his bone age was advanced. Nothing else was wrong. He shouldn't have had a bone age of 4.5 years. It was quite clear. So the second case was a little girl aged 12 months, referred because she had pubic hair present for 6 months. She didn't have thelarchy or any other evidence of virilization. There was no relevant past history or family history apart from PCOS maybe in her mum. She was tall. She had a little bit of labial pubic hair, which is more important than pubic hair on the mons and does suggest an androgenic cause. However, she had no clitoromegaly and there were no other signs of puberty. She had some investigations, all the same investigations you will notice, and the only one that was abnormal was that her testosterone level was 2 nanomole per litre with an upper limit of normal of 0.7. It was a bit odd too. Case 3 was a completely normal baby born at 40 weeks, but in our institution now we have newborn screening for CAH, for 21-hydroxylase deficiency, and this child had a newborn screen. He was, sorry, that's back to front, so I'm sorry. You can see there's no normal ranges even written on that slide, but you can see that once again, there was a slightly raised 17-hydroxyprogesterone, which then on a repeat sample returned to normal, but he had an enormous level of testosterone, which subsequently dropped. At the age of 2 months, he was completely normal in height, weight, blood pressure, and was not virilized. So where did that testosterone come from? And the last case was a 6-year-old boy who had a 3-month history of increased pubic hair and increased size of the penis. His parents reported that his facial structure looked a bit more mature, and they had seen that he'd been growing very fast. Other than a history of asthma, he had no other past history. He was extremely tall, above the 97th centile in a family on the 50th, and he was well through puberty in terms of phallic development and pubic hair, but he had 2 mil testes as well. And he had some investigations, all the same investigations. His testosterone level was well in the adult male range, but his bone age was consistent with chronologic age. Another strange one. So there we have a summary of the 4 patients. I won't go through them again. So what are the differentials for androgen excess? I don't think at this time we have time to ask everybody, but just think about it for a second. Congenital adrenal hyperplasia always has to be considered, usually 21-hydroxylase deficiency. One would not like to miss, particularly in those babies, an androgen-secreting tumour, either of the adrenal or very occasionally of the testis. A beta-HCG secreting tumour will do the same thing, or exogenous androgen, or rarely testotoxicosis. I hope everybody thought of all those causes. So there we are. So there's case 1 again. His dad turned out to be taking testosterone cream given to him by an endocrinologist for a low testosterone. He was applying it to his shoulder and waiting 30 minutes before rubbing it off or having a shower. The little girl's father was also taking testosterone cream. We don't know why, and we don't know which portion of his anatomy that he was applying it to. The third child, who was picked up by accident, his dad was on testosterone cream again by a wellness GP. He was doing shift work and night shift, and he had one single random low testosterone level, which had caused him to go to the GP and get this treatment. And he was putting it in his axillae. And the last patient, who was grossly virilized, his father was also using testosterone cream for a low testosterone, apparently, and he was applying it to his inner arms, his chest, and curiously, his knees. And then he was co-sleeping with his child. So this is what I want to remind you about. In our country, there's an authority required for the use of testosterone of any sort, particularly in this case of gels and creams for established pituitary or testicular disorders. The patient must be treated by a specialist, must be reviewed generally, must have the treatment applied to the scrotal skin, except that this week they made a new regulation with a new cream that you can apply just anywhere. So looking at the pharmacokinetics of topical androgen, when you put topical androgen on normal skin, it forms a depot under the skin in the stratum corneum. And the reason that it is used on the scrotum is that there's very, very little stratum corneum, and so you get a blood level much more quickly. There is a transdermal patch, but nobody uses it because it's a 30% risk of allergy, it's unsightly, and it usually has to be applied to the scrotum, so it's really not used. So if you look at this, is from David Handelsman, a very reputable andrologist, looking at a small number of healthy men who were given nandrolone decanoate to suppress their own testosterone levels, and then they were given transdermal testosterone cream applied to the scrotum in a random sequence with at least 2 days between doses. And you can see that the peak level of testosterone achieved in 2 hours after application of the testosterone was well in the adult male range, 16 nanomole per litre. And if they put it on their abdomen, the peak level was similar. How long does it stay there? Well, it depends where you put it. It depends on the concentration of the testosterone and other components, but it also depends on whether you bathe and what clothes you're wearing. So these are a couple of publications on looking at particular subjects who did a formal study. They had 15 minutes skin contact 2 hours after the testosterone gel application. And another lot were covering the application site with a T-shirt, and that mitigated the transfer. So of the ones who had the 15 minutes of skin contact with somebody else 2 hours after the gel application, the testosterone level in their female partners went up nearly 3 times to baseline. If they wore a T-shirt, it reduced it by somewhere between 40 and 80%. And if they washed their skin prior to contact with their partners, there still was residual testosterone. So there's a new testosterone gel formulation where showering after application reduced the dose by 50%, and the package insert suggests avoiding having a shower for 6 hours. Well, presumably most people will not put the testosterone on in the morning when they're going to work. They'll probably put it on in the evening when at home. So it's all very difficult. This is the amount of testosterone on the clothing itself after it's been laundered. 12 subjects applying the testosterone to their armpits. 13% of the mean dose remained in the cotton before washing, and it transferred to other clothes in the washing machine. And there's a warning on that particular gel saying that virilization has been reported in children who was exposed to testosterone gel, and that children should avoid contact with unwashed or unclothed application sites for men who use these substances. And healthcare providers should advise their patients to be careful. The trouble is that children have very thin skin with increased skin permeability. They've got a big body surface area to volume ratio, and they're much more likely than adults to have prolonged contact of being held by their parent for hours perhaps, and also in some cases sharing a bed with a parent. And this may have effects on their growth if long-term exposure and on their final height outcome. And this is a study from Australia looking at variable persistence of testosterone in infants compared with children who had been exposed to topical testosterone. And what you can see there is the first 2 children had a presentation under the age of 1. The testosterone levels that were achieved were between 12 and 21 nanomole per litre in the adult male range, whereas the 5 and 6-year-olds also had raised testosterone levels, but only about 10% of the babies. And this is just a study from New York looking at a pair of twins, dizygotic twins, born at 30 weeks preterm. One twin was supposed to have clitoromegaly, but had a normal level of testosterone at birth, which then interestingly rose 12 months later. Whereas the second twin presented at the age of 2 with clitoromegaly and pubic hair. The father, of course, was using testosterone gel, and when the parents separated, the testosterone levels went away. So if you look at the literature review of all the pediatric cases of virilization secondary to exogenous testosterone, the age range is between 8 months and about 6 years. All of the parents, sometimes both parents, male and female, have been using testosterone gel. And the levels of testosterone, again, are much, much higher in the babies and small children. And this may lead to secondary central precocious puberty. If you get a testosterone level in a little boy in the adult male range, this may stimulate the hypothalamic pituitary axis. So this is something new that we have to think about. Topical testosterone preparations are highly transmissible. Prescription by, should I say, dubious doctors for dubious reasons are increasing massively worldwide. And it's likely that testosterone exposure is occurring very frequently to infants, to children, and to female partners. And it may be that women who are coming in with apparent polycystic ovary syndrome of late onset may very well have exogenous testosterone exposure. Risks, of course, need to be emphasised to the patients when a prescription is given, and has to be weighed up if they really do have testosterone need, against the use of a parenteral preparation, which of course does not have those risks. Unfortunately, it is possible to buy testosterone gels and creams on the internet, and this is absolutely universal and can be purchased anywhere by anyone. So we need to promulgate this information and educate families everywhere about this problem. Thank you.